Hello and welcome to our session on transforming Africa's health crisis with telemedicine. It's an absolute privilege for me to be speaking with you today. My name is Yaya Mbaoua. I'm a business and product executive with over 20 years of technology experience. I'm founder and CEO at Zense and the Mbaoua Group, a healthcare technology company based in Abidjan, Côte d'Ivoire. In other healthcare technology leadership roles, I served as Vice President of International Sales and Business Development for MedOne Healthcare in McLean, Virginia, and Vice President of Product Management at Raleigh Health in Washington, D.C., where I guided the launch of a consumer platform for self-health assessment, management, wellness, and disease prevention. I also consult with GlobalMed, the world leader in telemedicine solutions. I'm fluent in French and German, and obviously I'm adept at navigating the cultural intricacies of international business and specialize in bridging the gap between business cultures in the US and Africa.
And greetings, everyone. My name is Krystylle Richardson, and I am so honored to be able to share with you today. I am the CEO of a quality and regulatory engineering consulting group, and I also have several other businesses and nonprofits. I am a business coach, author, radio show host, and have over 38 years experience actually in international business, engineering, leadership, operational excellence, public speaking, and more. And this is across about 25 different countries. Related to what I've done from a consulting perspective, I have been the Director of Quality and Regulatory for GE Healthcare, the VP of Quality and Regulatory for Applied Microarrays, the Acting Director of Quality and Regulatory for Proteor USA, Fusion Orthopedics, and more. I am a best-selling author and have authored 7 books and counting. I have a radio show, Soaring with Eagles, as well as Above Your Best. These shows have been listened to in over 40 countries with thousands of listeners. I'm so happy to be with you.
Great. So today we'll talk about what a successful telemedicine deployment in a disadvantaged area looks like. So we'll start by reviewing the learning objectives for this session, and then explain how telemedicine is addressing the healthcare crisis in Africa. We'll walk you through a pop-up virtual clinic in Ghana, and then a much larger deployment in Zimbabwe that was the collaborative effort of multiple government and humanitarian organizations. And finally, we'll discuss recommendations for training, logistical and infrastructure needs, and for project management. So let's start by reviewing our objectives for this session. By the end of our talk, you'll understand how to formulate the infrastructure needs for global telehealth deployment, integrate the different components required for successful collaboration among multiple stakeholders, and identify the training and education needs among providers, patients, and staff. So let's talk about Africa, its challenges, its needs, and more importantly, a solution that can help. The World Health Organization says Africa confronts the world's most dramatic public health crisis. And that includes high rates of communicable diseases, rising chronic conditions like diabetes and heart disease. 19 of the 20 highest maternal mortality nations are in Africa. Africa also has the highest neonatal death rate. And 60% of the world's HIV/AIDS cases are in Africa, despite having only 11% of the world's population. So we talked about the problems. Now let's talk about a solution. Telemedicine is known for bringing care to the underserved, but many underserved patients live in areas with inherent logistical challenges, like lack of clinicians, inability to access proper transportation, electricity and internet access can also be challenges. So an effective virtual health deployment can really work miracles, but only when leaders bring the right clinical expertise, the right technology, and an intelligent strategy. And that brings us to our story today, which is really two stories of how virtual care transformed rural Africa. A small grassroots mission in a rural Ghana village and a United Nations funded deployment across Zimbabwe. These deployments change lives. But we're not just here to inspire you, we're here to talk to you about planning, preparation, collaboration and foresight, the challenges that we ran up against and the lessons that we learned along the way. We'll share some of our recommendations for launching clinically effective and on-budget programs across disadvantaged regions. So let's start with a small Ghana mission organized by Krystylle Richardson. Krystylle?
Yes, thank you, Yaya. So as I mentioned in my introduction, I have several nonprofits, Full Color Movement International and Telehealth United. I am a licensed missionary and minister and counselor. This particular mission was in Ghana. I've also done missions though in Senegal, Nigeria, Kenya, as well as Jamaica, Barbados, and the Bahamas. Part of the reason for doing these missions is because my parents raised me to be a giving person. They were so giving. And I went on my first trip in high school and then in college, and it just kept going on from there. So what we're going to talk about today is a telemedicine mission in Kumasi, Ghana. So let's talk about launching a pop-up telemedicine clinic. When doing this, there's 3 keys: coordination, creativity, and communication. Let me say that again: coordination, creativity, and communication. There was a lot of things that had to be coordinated related to providing teams in America and Ghana. We also had to train medical staff in Ghana related to what we were going to do in the mission, how we were going to set up the stations, and also using the mobile examination unit. We had to prepare packets related to the patient education and awareness of what we were doing, as well as related to general health. Another portion of the planning had to do with confirming internet access and electricity at the clinic sites. Part of this was because we were bringing a mobile exam station designed to provide evidence-based care in remote locations, as well as a sophisticated military-grade PC, an integrated high-performance camera for video conferencing, and connective diagnosis tools. Part of the creativity came into play when the pastor created a number of flyers to announce that we were going to be doing 2 clinics for this particular mission. We also had to align protocols related to what the doctors were going to communicate between America and Africa. So now I'm just going to go over some things related to the 2 clinics that we did. Our services were in high demand. We did fecal tests, ear and eye exams, cheek swabs, ultrasound, ECG, and more. We had hundreds of people that wanted to be seen. This caused the medical staff, including myself, to be on call and on point in these clinics overnight. We saw over 400 patients and did over 1,000 exams in 2 days. Some of the patients walked miles and miles on foot to get there to be examined. While we were there, we also had to do some coaching of younger residents who wanted to be seen by doctors and also wanted to pursue being a doctor as part of their career. If we go over a few lessons learned, one of the things I want to talk about is the fact that you have to be prepared for the expected as well as the unexpected. Small clinics, even the small clinic that we did, it changes lives. And this was very, very humbling to see how all of the people that came to be seen really appreciated us being there. Part of the lesson learned was that we needed to ensure that we had backup plans because of the blackouts and brownouts that happened related to the electricity. Another lesson learned was to expect overwhelming demand for care. There were so many people that needed to be seen. That was one of the reasons I mentioned that we even had to stay overnight to make sure that we saw everyone that needed to be seen. Lastly, we need to create an ongoing culture of care and education. This is key, even for a temporary clinic based on what we did in Kumasi, Ghana. Now I would like to turn it back over to Yaya.
Okay, thank you, Krystylle. I'd like to now talk about a telemedicine deployment that has also changed lives. It's a pilot program funded by the United Nations to transform healthcare outcomes across Zimbabwe. The pilot began in Zimbabwe's Manicaland province, one of the 10 provinces in the country, where the Ministry of Health and Childcare wanted a solution to the local healthcare crisis. Most rural clinics in Zimbabwe lack a resident doctor, and in some villages, the only healthcare they get is a monthly visit from a travel nurse. And in even smaller villages, a sick or injured patient must be carried on foot to wherever the closest nurse is. And patients with complex issues and chronic conditions like hypertension, diabetes, heart disease often go untreated. And in some areas, the terrains are inaccessible by road, making it almost impossible for an ambulance to reach a patient in time. So the pilot deployed telemedicine across 16 clinics, specifically through mobile exam stations, medical examination devices, and software applications. By connecting clinicians and remote patients through real-time consultation, the telemedicine deployment was intended to bring primary and specialty care to residents, reduce the need for ambulances, and transform health outcomes for entire villages. So leaders collaborated with the Ministry of ICT and POTRAS, which is Zimbabwe's telecommunications regulatory agency, to win funding from ITU, a United Nations agency based in Geneva, Switzerland. So in Zimbabwe, ITU and POTRAS began collaborating and coordinating the distribution of responsibilities. And as the main sponsor of the project, the ITU worked with clinical experts and the equipment vendor who provided telemedicine stations and devices such as high-definition cameras, stethoscopes, ECG, abdominal ultrasounds, and vital sign devices. And they also handled equipment shipping and delivery, including working with the Foreign Affairs Office for tax exemptions. And as the main beneficiary of the project, the Ministry of Health and Childcare provided a list of rural healthcare facilities that will participate in the pilot phase, and also the list of practitioners to be trained. So clinicians and IT specialists from various locations in the Manicaland region were convened to a week-long training session that took place at the capital city of Harare. And the participants were assigned to the telemedicine stations specifically configured for their respective deployment sites. And we also conducted local training sessions at the facilities to reinforce the training from the previous week and train other staff that did not travel to the capital city for training. And as the co-sponsor of the project, POTRAS handled the procurement and installation of the power backup systems and also defined the technical specifications for the RFP. They also provided technical staff to handle implementation and deployment and participate in the project monitoring and evaluation. And they oversaw the collaboration between ITU and the Ministry of Health. So they handled system configuration, set up internet access, and connected all the equipment to the internet. Well, after a few weeks of deployment, the initial consultation volume was very low, mostly because of lack of confidence in using the systems. Some of the staff sent to training workshops had no direct involvement with the telemedicine equipment, which really missed the opportunity to train the right personnel who did use it ultimately. But the biggest staff challenge we had was that many staff from the rural clinics were skeptical about the new technology. They didn't believe that the telemedicine could be effective and that the equipment will operate as promised. So porters had to revisit the facilities for a refresher training. There were also some network-related issues that prevented continuous use of the systems. For example, in major cities, facilities are providing internet access through fiber cable, whereas in remote areas, they are using VSAT, the VSAT system. And unfortunately, the VSAT system were damaged because of a natural disaster. So porters had to return to the facilities to restore the equipment and re-establish internet connectivity. Another major challenge that we face involved Zimbabwe's regulatory framework, which governs the storage of sensitive data, such as health information. Obviously, the telemedicine solution was designed to help physicians save their medical consultations onto the cloud, but the regulations forbid that. However, they were able to find a way to mitigate that problem by redirecting all health records to a locally hosted data center. In the end, the Zimbabwe deployment launched successfully at all 16 healthcare facilities across the country. That's 12 rural clinics, 2 district hospitals, 1 provincial hospital, and 1 national referral hospital in Harare, the capital city. All telemedicine stations and devices have been performing with high reliability, and the trained providers were able to train other staff at their facilities, and the number of virtual consultations just gradually started rising. And the pilot has been able to reduce the need for ambulances. Patients in those areas were receiving faster services and more advanced medical expertise. Now let's talk about some of the outcomes of this program. As a disclaimer, this has been a pilot project, so we don't have a ton of data to share with you in terms of outcomes, but there are some really small, quick wins that we wanted to touch on, specifically as it relates to the travel reduction for patient referrals. For example, referrals from rural clinics to district hospitals save patients an estimate of 75 kilometers of travel, and with an average of 10 referral cases recorded per month per site, and we had a total of 12 rural health centers referring patients to 2 district hospitals. And the telemedicine consultations with specialists were scheduled for once or twice every week, except in cases where there's an emergency. And for referrals between district hospitals and the provincial hospital, patients would save an estimate of 150 kilometers of travel. And we recorded an average of 5 referral cases per month per facility. And we had 2 district hospitals escalating to 1 provincial hospital. And here, the consultations were scheduled on an as-needed basis. And the last level of referral occurs between provincial hospitals and the National Referral Center, where the intent was for patients to obtain second opinion between specialists or for care that requires specialized service like neurologists or surgery. And now let's talk about some of the outcomes in terms of specialty care that was now possible for residents in those rural areas. And the top areas with the highest frequency of cases were maternity cases for women, pediatrician services for children, chronic illnesses, that's for all age groups, optician services, mostly for the elderly, and physical injuries as well. And the telemedicine consultations primarily focus on complicated medical conditions that require specialized medical attention. And in most cases, it's a case where a local clinician feels that it falls beyond their expertise, so they have to escalate to a specialist from the district level or further to provincial level. But for most cases, they were handled locally by a general nurse, so the total number of telemedicine consultations dropped relative to the number of total consultations done per rural site. And this is done to avoid overwhelming specialists at referral centers with less complicated or minor cases. So now let's talk about a few specific ways this telemedicine program has been helpful in Zimbabwe. Well, the telemedicine deployment has offered a massive advantage after a tropical cyclone called Yaya struck Zimbabwe and Mozambique in March 2019. That's just over a year ago. And it was one of the worst tropical disasters on record in Zimbabwe. And it caused catastrophic damage across the country and left more than 1,200 people dead, with thousands wounded and thousands missing. And the telemedicine clinics relieve pressure on overwhelmed hospitals by providing remote consultations during the disaster management and recovery efforts, and helping wounded patients see doctors immediately instead of waiting for care. Another story of how this telemedicine program helped in Zimbabwe is the story of Dr. Shoga, who was an obstetrician and one of the doctors I trained in Harare. And after training, Dr. Shoga returned to his district hospital where he had a strong relationship with his patients, mostly expecting mothers. However, Dr. Shoga was awarded a grant to pursue further medical education in the US, but he was still able to see his patients back in Zimbabwe via the telemedicine program, right from the US. So every Tuesday morning at around 11 a.m. local time in Zimbabwe, patients line up to have a remote consultation with Dr. Shoga, facilitated by a local nurse. So this is an example of how African doctors can expand their medical expertise while maintaining consistent care with their patients back in their home countries. Now let's talk about recommendations. And let's start with recommendations for training and awareness. Because these deployments really were successful, but eliminated some blind spots and improvement opportunities. So you'll be dealing with providers from different regions and backgrounds and ages. So you need to align them on best practices, procedures, and care protocols. And you should expect a generation gap in terms of technology adoption, because some older clinicians, especially in rural areas, were a bit reluctant to adopt the new practices because they have been using the paper-based manual process for decades, and they presented real difficulty with using technology. So we visited the facility to provide them with one-on-one training. They were even offered incentives. For example, they were offered free mobile airtime because nurses needed to place calls to schedule visits with doctors. So they were offered free airtime they can use to make those calls, and the airtime was generous enough for their own personal use. Some clinicians were even offered free tablets as personal gifts to help them familiarize themselves with technology for their personal use, just enough to ultimately feel comfortable using the technology, the telemedicine system, to do consultations. And another takeaway is also that education patients through community awareness campaigns is critical. So flyers were created to introduce them to the concept of telemedicine, and local leaders were enlisted to have conversations with their communities as well. So now let's talk about recommendations for infrastructure and logistical needs. Well, every telemedicine deployment requires careful planning when it comes to infrastructure and logistics. But when you're deploying in a disadvantaged area, that goes double, since many resources may be unreliable. So you need to establish electricity standards, internet access, and security requirements. And that includes shipping regulations and storage needs for the telemedicine equipment. And in the extremely rural areas, transportation could be a challenge as well. For patients who lack, cars or public transportation, the clinics must be accessible. Has to be in a location that's most convenient to the population. Otherwise, you'll be excluding some really sick patients if you don't take that into consideration. Now, let's talk about recommendations for project management. It goes without saying that it's critical to adopt really, solid project management methodology. Roles should be clearly defined with contracts designating responsibilities and resources. and that avoids gaps and gray areas. And you need to allocate resources efficiently. Is absolutely critical in achieving the deployment goals. And deploying telemedicine in a large geographic area often means a higher implementation cost as well. So it's really important to keep that in mind. And in this particular situation of multiple organizations being involved, multiple stakeholders being involved, it's important to establish a steering committee to champion the successful implementation and acquire buy-in from all critical stakeholders. And the stakeholders must also view the telemedicine project as an essential element of the national digital health strategy, because approaching telemedicine as a standalone technology will create silos, unnecessary silos, and that's not something that's recommended. And it's also critical to involve high-ranking government officials. It's helpful to do that. And of course, you can imagine that the deployment involves different facilities and villages, each having different needs and scenarios, so the implementation has to be tailored accordingly, instead of just having a one-size-fits-all approach. But you should always be ready for surprises and have backup plans of backup plans. So at the end of this pilot program, higher government officers have considered expanding the pilot from the initial 16 clinics to 96 healthcare facilities throughout Zimbabwe. And now I want to share a quote from Mr. Cosmas Chigwamba, who's the principal director at Zimbabwe's Ministry of ICT, who says that telemedicine is an enabling and transformative technology, and the program will greatly contribute to the sustainable socio-economic goals of his country.
Wow, thank you, Yaya, for that phenomenal overview of a large-scale telemedicine deployment in Zimbabwe. And we would like to also thank all of you all for attending our presentation. We hope you can take away some ideas on how you can organize a transformational healthcare mission as well. Whether it's through a large-scale deployment or a small clinic that changes lives, one life at a time. Please complete the online evaluation of our session, and please reach out if you would like to have further conversations. Thank you.